This is Breakthroughs. I'm Erin Spain, host of this podcast. Some of the sickest COVID-19 patients have irreversible lung damage with little hope of getting off a ventilator. But now there's evidence that a double lung transplant could save their lives. In June, Northwestern Medicine surgeons performed the first known double lung transplant on a COVID-19 patient in the United States. Since then, 7 more COVID-19 patients have received double lung transplants at Northwestern Medicine, a total of 8 patients, the most performed at any health system in the world. These patients have gone on to recover at a rapid pace. In a new paper in Science Translational Medicine, Northwestern investigators share findings that support this intervention. It is the first paper to detail why lung transplantation should be considered for patients who have developed irreversible lung disease due to COVID-19. Dr. Ankit Bharat is the first author of this paper and the chief of thoracic surgery at Northwestern Medicine and director of the lung transplant program. Dr. Bharat and his team are responsible for performing these surgeries, and he joins me today. Welcome.
Well, thank you for talking to us.
Well, you've been on the front lines of this pandemic since the very beginning, and many of your days are very long. How would you describe your experience during this pandemic?
What I'll tell you is we take great pride in being able to handle lung problems and lethal lung problems, many different types. So when this pandemic started and then we started to get hit by all these cases, we were so humbled by the effects of this virus and not knowing what the right treatment for these patients should be. And as proud as we've been, all these years in our ability to take care of these patients, we were also quite humbled to see all these people dying. So we were honestly quite desperate to figure out mechanisms to help these patients as best as we could. We were trying desperately to try and create treatment pathways to help these patients, both on the medical front as well as on the surgical side. We had developed rapidly programs that could support these patients with the ventilator, as well as advanced devices such as ECMO when the ventilator was not enough. And then we were obviously involved with a number of clinical trials trying to figure out what drugs are going to work the best in these patients. We're just working, really hard to help as many patients as we could. But then quickly, our resources were getting stretched really thin, and obviously with the fear that was associated with the virus, our ability to conduct really extensive research with human tissues that were infected with the virus was also hampered. We didn't quite even understand what's the safest way to handle those tissues, bring it to our research labs, and conduct those experiments. We didn't have our ability to grow the virus in the lab because, again, it was a highly infectious bug. So given all those restrictions and limitations, we are trying still our best to figure out how to help these patients. And all specialties were doing that, whether it was the infectious disease, whether it was the ICU doctors, whether this was the pulmonologist or the surgeon. So from the surgical perspective, what we were trying to do was figure out ways to help these patients if they got to the point of permanent lung damage, which we knew that's going to happen, and we observed in a number of those patients. That's how the idea of potentially thinking about lung transplant as an exit strategy came about. And we started to perform certain studies and investigation to see if this is going to be feasible for certain patients who get to this point of no return.
In this paper, you report the results of lung transplantation in 3 patients with non-resolving COVID-19 associated respiratory failure. Now, you also detail findings that came from the examination of lung tissue from those transplants, as well as autopsies from patients who died from the virus. First, tell me about those 3 transplant cases and why lung transplantation was the only hope for survival.
This study is based on human tissue that has been obtained from the transplant recipients, as well as some patients who had died of the virus. So we had started early on this program of warm autopsy. What that means is within a certain amount of time after a patient expiring from or dying from this virus, we would have to collect that tissue. And typically that was within 60 minutes. So if the patient died in the ICU room, we would actually enter that ICU room with all our protective gear, and then we'll open up the chest cavity, isolate the tissues, and then conduct that studies. Obviously, this was after obtaining consent from the patient's family, and we are quite grateful to those families for allowing us to do that and understand how this virus damages these lungs. Also, as we did the transplant on these patients, we were able to use the discarded tissue, the discarded lungs, basically, that we are taking out, and understand some of the, the biology behind the damage that the virus does. These patients that were transplanted, the decision to transplant was based on the early analysis of the warm autopsies. And we were looking at a number of questions. And I'll probably outline a few of those questions. There are a lot of questions that we needed to find answers for, but some of the most important questions were the following. The first question was, have we truly gotten to the point of no return? Meaning, how can we establish that the virus can cause permanent damage and the lungs are not going to get better? And the reason why that was so important to establish was the transplant should really be the treatment option of last resort. So if the patient's lungs could get better, the spontaneous recovery is always a preferred option. So we don't want to pull the trigger for transplant too soon and avoid the patient of the chance of lung recovery. So we needed to establish that, and by taking the tissues out from these patients who had died, we were able to compare the tissues in patients who had died early on in the disease process and patients who had died late in the stage. So what we call late stage COVID versus early stage COVID. And using some new techniques such as the Shields tissue clearing technology, which we have described in that paper, something that has not, to the best of our knowledge, has been performed in the context of human tissues. Using that technology, we were able to study the basic framework of the lungs affected by COVID. What we found was in the late stage COVID, the basic framework of the lungs is completely destroyed. So there is no chance of recovery. Now, normally when you have infections in the lung, the framework is intact. So you can have these, what we call the progenitor cells, which are the cells that are responsible for recovery of the lung and repair of the lung. They could migrate along that basic framework and then repopulate the lung and repair the lung. But once the basic framework is destroyed, there is no chance for recovery. The way I explain this is using an example of an earthquake. So if you have a very minor earthquake and you're living in your house, multi-story house, and you have a little bit of damage with your wall paintings kind of falling apart and your furniture rolling from one place to the other, you can still fix that house. You can refurbish it. You can put those paintings back, put the furniture back. But if the earthquake is so severe that the whole building gets leveled, then you have to replace the house. And the COVID lungs in some patients follow that same analogy. The earthquake is so severe that the whole framework of the lung is destroyed and there's no chance for recovery. So we were able to establish that. The second important point was, can we be really sure that the virus has cleared, or the host has cleared the virus? So that was very important for us to understand, because we had that concern that if you transplant someone with the virus still in the body, this virus will likely recur. And it will likely recur because patients after the transplant would need immunosuppressive medication. So it was very important for us to really understand and develop tools to make sure that the virus has cleared from the body. And also, like I said, make sure that the host can clear the virus. So we did that by using a single molecule FISH, a relatively new technology. We were able to study those lungs, and using this technology, we were able to see the virus in the lung and see it replicating. So what we found was in patients who had late stage COVID, they truly cleared the virus, but the damage is there. So those, I would say, were the two most important questions. And once we had addressed those questions, that's how we came to the transplant. The first transplant was in a young woman who was really healthy, in her 20s, and she was really minding her own business, following all the CDC guidelines, staying at home. And then she gets this COVID. Very quickly, she got to the point of having pretty severe lung damage. She needed to be placed on the ventilator as soon as she came to the emergency room. And then we had to escalate that treatment to putting her on ECMO, which is the highest level of heart and lung support that any patient can get. And then we waited. We gave her time for the body to clear the virus, and we established that using the standard testing, but also some of the tools that we had discovered and developed. And she had cleared the virus, but then her lungs were just not getting better. So we waited a number of weeks, trying to give the lungs a chance. We did the best treatments that were available with steroids and remdesivir, all those things that were being studied and being advocated for the treatment of these patients, and there was no recovery. In fact, she started to get one complication after the other, with bleeding into her lung collapse, spontaneous bleeding from her liver, and then she started to get infected by these really, really nasty and aggressive bugs. One of them called Serratia. And then as we tried to treat that bug with the antibiotics, that bug developed resistance to the antibiotic. And as a result of that, her lungs started to get necrosed and just die. So she was really critical. In fact, I remember one night she was so sick that we had called her family from that lives out of state, and informed them that she's likely not going to survive that night, and they should, come and probably be prepared to say final goodbye. And so they traveled and through the pandemic to say final goodbyes. But fortunately, we were able to get her through those complications. And then I had that discussion about transplant with her, which went really well. So that's briefly about her. She clearly did great, and she's now at home, running pretty much every day. She's off oxygen and looks like a normal person. The second transplant then was after we'd done the first transplant, the news got out. And that was one of the big messages that we wanted to get out there after the success of our first transplant. We wanted to teach the community and inform the medical community in the country that this could be a life-saving treatment for patients. So then we got the referral for the second patient from another hospital within our region. In fact, I went to that hospital to see the patient and talk to the patient and his wife and discuss the treatment option for lung transplant. And similar to our first case, this patient had been on ECMO for a number of weeks and actually a few months. He ended up being on ECMO for about 100 days before transplant. That is the second longest. That was the second longest at that time. And then we did the transplant. Again, like the first patient, he's otherwise was trying to mind his own business and do anything crazy, but he was also quite healthy at baseline with no conditions. So that was successful. And then finally, the third transplant, which was sent to us from Washington, D.C. And this individual was very unfortunate, very healthy baseline, no major medical conditions, and then just gets the COVID, gets placed on the ventilator, and similar to the first two, goes on to ECMO. And then the lungs didn't get better, and he had one complication after the other. In fact, he had a stroke related to the COVID, but fortunately he got better because he was a little bit younger. He developed kidney failure, which we helped get him through that, and then finally be transplanted.
And these were very critically ill patients, as you described. So based on your study, is it safe to perform lung transplantation on critically ill patients, even those suffering from infectious cases of lung failure, such as COVID-19?
Yeah, so I think one of the most important points of this study that we published is to establish lung transplant as a treatment options in patients who are as sick as the ones that I just described, which is a big paradigm change in the context of organ transplant, and especially when we talk about lung transplants. And the second thing that our study shows that it's safe to actually perform lung transplant in infectious causes of end-stage lung problems. The current thinking is that patients who have suffered from a permanent lung injury, they can be considered lung transplant candidates as long as they are participating in outpatient rehab, they're coming from home, meaning they have developed a chronic lung and what we call end-stage lung condition, but they're stable, they're functional, they're being able to carry on their day-to-day life with oxygen support and so forth. It's not considered to be a treatment option in patients who've had acute lung failure and who spend weeks and months in the ICU, and certainly not in patients who've been on ECMO. And the reason for that is because there is a general belief that patients who are this sick they will not survive the lung transplant. See, double lung transplant is considered to be one of the most complex surgical procedures that can be done in any hospital anywhere in the world. So you take these really sick patients who spend weeks and months in the hospital on ECMO, they've been immobilized, they've suffered through multiple complications. So there is this general belief that these patients are not going to survive lung transplant. So it's not been performed. The second thing that I mentioned was it's also not done in patients who have an infectious problem leading to end-stage lung disease. So, for example, we've not typically done this in influenza patients or bacterial infections that lead to this. So that is based on the concern that perhaps if you transplant these patients, those bugs that cause the lungs to fail in the first place will return after the transplant, especially in the setting of immunosuppression. So this study brings in a paradigm change in our thinking about lung transplant. And we certainly can say that these patients do just fine. And this is, I think, important to consider because unlike other patients who come in with years worth of, suffering from chronic lung conditions, these patients were just completely fine weeks or months ago. So their basic body, their biology is actually fine, and they had a short duration illness. So once you fix their lungs, they recover rapidly. And we've seen that in the 3 patients that we reported and the subsequent 5 patients that we've transplanted. We've had 100% success rate in these patients. And that's actually, ironically, although I acknowledge that the sample size is small and we cannot make far-reaching conclusions, but even in these 8 patients, if you look at 30-day survival, which is an important landmark when we look at transplant outcomes, we've had 100% success rate. That is actually, in my opinion, better than the non-COVID transplants that are being performed nationally. The reported outcome at 30 days nationally for all these other transplants that we perform is about 97% at 30 days. Now, we will have to see what happens at 6 months and 1 month. At 12 months, but the way these patients are looking right now, I'm quite confident that their long-term outcomes are going to be same, if not better, than the other transplants that we perform.
And when you remove this tissue, the lungs, tell me what that looks like. You're getting a glimpse at some very damaged organs.
We jokingly say, after the transplant, especially COVID transplants, how many gray hairs you get. On average, jokingly, we used to get, you're not supposed to get any gray hairs when you do a normal transplant, but with these, you at least get 5 to 10 gray hairs every transplant. These are really tough operations. And not only because these patients are really sick to begin with, the actual operation is so difficult because the virus and the associated damage from the virus has completely changed the anatomy. And these lungs actually don't even look like lungs. They're stuck everywhere to all the surrounding structures. You have to do very delicate dissection to separate these lungs out from the heart and from the surrounding structures like the chest wall, all the individual ribs, the diaphragm, all the nerves that like the phrenic nerve which supplies the diaphragm. You have to really carefully peel all that. And everything that you peel, it bleeds because they haven't formed mature scar. There's a lot of scarring, but it's very inflamed and very, very immature. So everything that you touch bleeds. Just to give you an example, if we do a normal transplant, the amount of the volume of blood that we have to use to do a transplant is less than 1 unit of packed red blood cells per lung transplant on average when we talk about non-COVID. But these patients, we use upwards of 15 to 20 units of blood. That's how much. And then these patients are so sick because all the fluid shifts that are happening as a result of the operation, they get very, very unstable during the operation. So you have to be quick, efficient, and you have to make certain very quick intra-op decisions to make sure that they don't crash on you. So these are really tough transplants because of all those reasons that I just described to you. And it takes a lot of patience and a lot of good decision-making to get these patients through the transplant. But I tell you, once they get through the surgery, they do just fine.
As you've said, these are very long surgeries, over 13 hours, and you recommend the double lung transplant in these cases instead of a single lung transplant surgery. Why is that?
So that is a great question and a great point about whether to do single or double lung transplant. So lung transplant, there are different types of lung transplant that can be performed. So you can, in different combinations. So you could do a single lung transplant, you can do a double lung transplant, you can do a heart lung transplant, or you can do what we call a lobar transplant, which only involves taking one of the components of a lung, which in medical terms is called a lobe. So that can also be done. So there are different combinations that can be done when we talk about lung transplant. But for COVID, we strongly believe that you have to replace both the lungs because what happens in these COVID lungs, that, as I explained to you in the earlier question, the basic framework is completely destroyed, and that's a setup for secondary bacterial infections, which are very, very lethal and very problematic. In fact, all of our patients that we've transplanted so far have had a second infection from a different bug. These are opportunistic bugs. They infect the completely damaged lung, and there's really nothing you can do in terms of antibiotic treatment to clear that, because antibiotics don't even penetrate the lung, because there is, these lungs become just big bags full of pus. So these bugs then can multiply unchecked, and they can cause sepsis and ultimately lead to the death of the patient. So we strongly believe that you have to replace both the lungs to avoid that problem, especially in the patients who've had this acute lung injury. You don't want to fix one lung and address the gas exchange, but then with the use of immunosuppression that is necessary after lung transplant, allow those bugs in the other lung to multiply and then ultimately kill the recipient.
So you've really detailed some of the clinical findings here, but there's also basic biological findings from this paper. You tell me about that, starting with the discovery of epithelial cells in the lung tissue of these patients that are really unique and may even be able to help screen patients in the future to see who is at risk of suffering such serious consequences from the disease.
First, using what we call this matrix imaging, which is based on a technology called Shield's tissue clearing technology, we were able to establish a method to study the framework of the lung. And using that framework now, we can build on that and start to identify how that framework gets destroyed by this virus. So we paired that analysis with what we call single cell RNA sequencing, something that we are very proud of, and being able to do it in a COVID lung. And to the best of our knowledge, this is the first such analysis published in the context of COVID lung. So what we do in this is we take the lungs and the autopsy, the warm autopsy that I described, we dissect the lung out into individual cells, and then we study the gene profile or the expression profile of individual cells. So thousands and thousands of cells, and you're studying all the genes that are being activated in those cells. And using that data, then we developed a machine learning, artificial intelligence-based analysis to study, to get some meaning out of that data. And then, very simply put, we compared the expression profiles of those cells with normal lungs, that we sequenced, or with lungs from damage from other conditions, for example, pulmonary fibrosis, sarcoid, cystic fibrosis, all those kind of things. So by using machine learning, artificial intelligence-based approaches, we can now take that data and ask questions, what's so different about these COVID lungs compared to normal lungs, as well as conditions that require transplant due to irrecoverable damage. So based on that and matrix imaging, and then validation by a technique called RNA-scope, we were able to discover certain novel markers that can not only give us novel insights into how permanent damage occurs in these patients, but also help us predict which lungs are recoverable and which lungs are not. So I'll give you a couple of those discoveries. So first thing that we found is the appearance of these cells, which are characterized by the expression of keratin 17. So these are epithelial cells, which we believe represent a differentiation defect. So normally when the lungs repair, they have Simply put, they have these progenitor cells that are responsible for the recovery of these lungs. So these are just the very basic. They can be compared to the stem cells in the lungs. So as the wound is trying to heal, these stem cells now then need to take the form of the normal mature cells that form the fundamental structure of the lung. So they have to go from being a baby to an adult. But when you have the situation of the COVID-19, that normal maturation of these cells from baby to the adult is defective. And that leads to the appearance of these keratin 17 cells, which we believe produce factors that cause fibrosis of the lung, which is another term for permanent scarring. Now, with biopsies, we think we can perform an easy biopsy through a bronchoscopy, which is not a surgical procedure, and then we can detect these cells and then predict whether the lungs will get better or not. The other thing that we've discovered is the replacement of a type of cell, which is called alveolar macrophages. So these alveolar macrophages are normal immune cells in all human beings, in every single lung. So these alveolar macrophages are completely replaced by a different type of cell called a monocyte. These monocytes are circulating blood cells. They are recruited to the lung in response to the virus. And their function is to kill or mount the immune response against the virus. But what happens is once the virus clears the body, these monocytes that have been attracted to the lung, they actually transform themselves into appearing like the alveolar macrophages. But the interesting thing is that these monocytes that become alveolar macrophages, they are the damaging cells. They promote the fibrosis and the scarring and leads to the permanent damage. And that's very, very fascinating to us and very important because in COVID, a very interesting finding is that the virus clears the system, but the damage perpetuates, it propagates far beyond the time that the virus has been cleared of the body. So why this also on a different context, why this is important is we believe that once the virus is cleared, treating the host using antiviral treatments or medications that kill the virus is not going to work. Giving antibodies against the virus once the virus is cleared down the road is not going to fix the lungs. So we have to design treatment options when you get beyond the first 7, 10, 2 weeks to control these signals that are leading to more scarring. Not try to kill the virus, but try to control the propagation of scarring, which is coming as a result of these keratin 17 cells or the monocytes and a number of other things that we've discovered.
There are so many findings in this paper. And right now, given the high number of deaths just this week, do you think there are people out there right now who could be saved with a double lung transplant such as this?
Yeah, so we get at least 3 to 4 phone calls every day from across the country informing us and asking us for help for patients in this situation. So unfortunately, a number of patients, it's too late because they have multiple other complications, multiple organ failure. But there are a number of patients who are, could be saved using transplant. As of yesterday, there were still about 27,000 patients in the United States that were deemed to be critically ill. And I believe there were over 5.5 million active cases. So those active cases, some of them will absolutely progress to the point of no return. They will develop lung injury and they will get to the point of no return. And out of those 27,000 critical cases, a number of those patients, in a number of those patients, lung transplant could save their lives. We just don't, unfortunately, have the capacity to perform every single transplant for every single patient in the country. So we are trying to encourage other centers to offer this treatment to their local patients. And hopefully this paper is going to help improve the confidence that this transplant can be done safely. It's certainly a difficult operation. It should not be done in centers that don't have the experience and in low volume centers, but in the right center with the right team, this could be absolutely life-saving. And I also expect that in the next few months, the need for transplant is going to grow until hopefully the vaccine kicks in and we hopefully avoid this problem in the future altogether.
Well, we know you are very busy during this time, so we're going to be wishing you the best of luck. Do you have some more surgeries that are scheduled?
Yeah, so we have several patients that we are evaluating right now, several patients that are on our list to be transferred to Northwestern from different parts of the country. We are just trying to prioritize based on our resources as well as the patient's conditions. So yes, we will be performing a number of those transplants in the upcoming weeks to months. But like I said, we are optimistic about the vaccine coming in, and if the data is what it looks like, hopefully the severe form of COVID will be greatly reduced or completely prevented. So as much as we've enjoyed helping these patients and saving their lives, we also don't want to do this over and over again, because it's a very tough operation and it does take a lot of resources, to get these patients through.
Well, thank you so much for your time. I know it's very precious these days.
Well, thank you.
For medical professionals who listen to this episode, be sure to go to our website to claim continuing medical education credit. Head to feinberg.northwestern.edu and search CME. And we encourage all of our listeners to subscribe to the podcast on Apple Podcasts or wherever you download your shows. And if you could, rate and review us too.